to
I'm going
you.
to start, and Bob is going to finish. We should go to the we were looking at the framework itself and thinking about how that needs to evolve or be refined based upon the conversations we had yesterday and people's insights from their day jobs, and to think about some of the research implications of that as well. So just to remind you, here's the framework, coupled with all the text that's in the perspectives paper. So the text and the paper go together, the framework go together. We spent a lot of time drawing outside of the lines, or at least thinking about what other lines needed to be added or what needed to be changed in the boxes. And so the first question that we had, if we can go to the next slide.
We're both doing it, sorry.
One back.
We were both controlling it.
Oh,
so
okay.
You can do it there from
Yeah. Don't trust either of the staff to hold the control. Okay, so the first question was what changes to the proposed conceptual framework were necessary, and we really talked about what didn't people get from the framework, what did they think were missing, what needed to be added. As I said, we were working outside of the box, so forget those 5 bullet points. We have about 7 or 8 here. One of the most, and this is in not necessarily the order that we would finally write it up, I think, but the first thing was more explicit discussion of teams and interprofessional collaboration. If we go back to the model, when we were originally creating the framework, a lot of the vision of teams were in that work organization box, and in the discussion it was clear that issues of team and interprofessional collaboration, coordination, work really extend beyond that work organization box and need to be incorporated into the framework more effectively. The second element was that when we wrote the perspective, we talked about the institutional level and the individual level, and the way in which our organizations actually carry out their work have many levels in between, units, operating rooms, et cetera. And if we're thinking of, and often there are certifications or credentialing at those intermediate levels, recognition at those intermediate levels, as well as the institutional and the individual level, and that those need to be taken into account more explicitly as we think about the framework here. There's a phrase and there's a box on the chart called invisible architecture, and we were asked to think about how to expand the visible architecture discussion as well. So that was a second element that came up in the discussion. The third was really expanding the environmental factors box, again, in several ways. You see it over there on the lower left as with a single arrow going to the C credential. In fact, environmental factors affect a great many of the boxes, perhaps less directly, and we were asked to think about an expansion there. We were also encouraged to think about other elements of environment that are not explicit there, either in the chart or in the text. The role of payers and professional organizations. We heard in the previous discussion of Group 2 the critical role of the business case and payers is, does this pay for itself, or alternatively, can you get payers to pay for additional credentialing? And that feeds into both the business case model in the outcomes at the very bottom, but also into the invisible architecture, the expectations and norms that are created both for individuals and organizations about credentialing. So really think about what else needs to be in that discussion of environmental factors. When we talked about the invisible architecture box, it was clear that what we've got there really, again, needs to be expanded a little bit more into what are the norms and expectations that this organization has about credentialing at the individual level. We heard that in some of the discussion yesterday from North Shore LIJ and Linda from Cedars-Sinai about their expectations as nurse leaders of credentialing, but also expanding expanding that. And interestingly, something which I don't think came up yesterday, which was the role of the leadership itself and how the leaders are credentialed in creating norms and expectations for others in the organization about credentialing as a key factor in trying to understand who gets credentialed and why, and whether the organization seeks credentialing. So that was in the, so we've got that, and again, not stopping at 4 or 5. We were encouraged to expand the nurse performance box, both in the text, or in the box, but also in the text, to really capture the richness of what nurses really do, how the credential and the competencies associated with credentials play into that, and to think about adding a temporal element, the fact that we start with nurses fresh out of school, fresh out of their licensure, and having a career path, which may include becoming more experienced, becoming more knowledgeable, and having credentials along the way. So really thinking about that nurse performance box and the way in which the temporal and career development plays into that and the role of credentialing in that. We got encouraged to add a lot of feedback loops that just weren't in the chart, from the business case back up to the organization, back up to the individual. And I'm not going to detail all of them, but clearly feedback loops were one of the things that were not fully reflected in our discussion. We were encouraged to think a little bit more about voluntary versus mandatory credentialing and how the model looks different, or what the components in those boxes or the descriptions in those boxes, how they look different depending upon whether you're talking about voluntary credentialing or mandatory credentialing. And we were also encouraged to expand that top box on credentialing and competencies to really differentiate a little bit more between what's being measured in the credentialing process itself and how that relates to the competence and capabilities of individuals to or institutions to deliver care and perform their functions. So those were some of the key. I wish I had that whole group in the room when we were developing the initial framework. It was an extraordinarily good conversation, an extraordinarily rich one, and I think added substantially to our understanding of what the framework was. Bob?
Thanks, Jack. Can we go to the next slide?
I
got it. All right, Bob, can you go to the next slide? I guess I can. The other part of what we talked about was this question. Based on that framework and the discussion that we had, what are the emergent research priorities in nursing credentialing to advance the field? So we had a lively discussion about a lot of different issues that we summarized here. We did not conduct a formal prioritization, so I won't say this is an exact representation of everyone's priorities in order or a consensus, but it had some logic to it. And I'll go through those. So the first was to standardize the definition of variables across systems and specialties. You'll see some common features between what Joanne presented, I'm talking about measurement and data, and what we're going to talk about here for obvious reasons, critical importance of getting our hands on appropriate data to be able to make these associations and causal pathways and understand these links. So coming up with definitions would be one. Second was the identification and measurement of relevant confounding variables. So there are many links between credentialing and the outcome, and there are many intervening variables that will confound the relationships and the associations that we might find across many domains. That whenever you decide you're going to show a link, somebody, your journal editor or reviewer or the CFO, will wonder, what about X or Y? So I think it's going to be incumbent upon the field to be able to think through what some of those confounding variables are and be able to get them measured and then brought into, like with number 3 bullet, implement these measures into the big databases. So we heard that before. And how to do that with validity, reliability, and efficiency. So it's really not good enough just to identify a variable and hope that it's measured well. We need to figure out what the variable is, and it needs to be established with validity, reliability, and because our clinicians and staff themselves are very busy doing many things, we can't just give them more tasks to do more measurements on a manual labor approach and hope that will happen. So the efficiency with which those measures get incorporated will have to be addressed. And there's research that can be done that, and then we incorporated social determinants of health in our EHR, and we're able to do that through a research project by comparing the nurses being able to incorporate certain measures on intake with research assistants doing that, and able to show that we could actually get valid and reliable measures from the nurses doing it without the research assistants having to do so. But that's a body of research that needs to be done for a lot of these different variables. The 4th one is the relationship between credentialing and competency, both at the individual level, the team level, and organizational competence. So we need to know that. We can't just assume that. We'd like to know the causal pathways. So if credentialing leads to a good outcome, is it because, in fact, there's some competency that might be the key pathway that leads to that outcome? And it might help us focus on subdomains about what are the most important things for people to be good at. The next bullet is the impact on clinical outcomes. So everyone pretty much uniformly believed that without the link between credentialing as the independent variable and outcomes as the ultimate dependent variable, you wouldn't get very far at being able to show the importance of credentialing. Now, the reason that that's down on this list is just really more of a sequential one. You won't be able to really show that very well unless you get these other measurement issues in hand and you have access to the data. But in many respects, I think this was the number 1 most important issue that people voiced. Now, we mentioned here a balanced scorecard because, in fact, there could be unintended consequences. There could be good unintended consequences. There could be bad unintended consequences. And so it's sometimes hard to imagine when your theoretical frameworks don't offer the opportunity to think of what could be a downside or what other impact it could happen. But by being broad-minded to look and think and measure, you never know what you'll find. And we have many examples of that where our presumed biomedical pathophysiologic models turned out to be wrong and not thinking about some other link. And we were able to reveal an issue of an unintended adverse effect from a drug. And so it happens with processes of care and labor as well. So we need to keep that in mind. The next bullet was the business case. We heard a lot about that yesterday, and if credentialing is going to be sold to the organizational leadership, then there'll need to be a business case, usually. We heard yesterday some organizations had chosen to go with credentialing based on the logic of it, but not all will be doing that. And so being able to get research on pulling together the right outcomes, economic outcomes, quality outcomes, labor force, retention, and a lot of other variables that add value to be able to get that. Ken talked yesterday about the importance of pulling together value and the links with the different kinds of reimbursement systems. And so those value propositions may shift and change over time, depending on the reimbursement system, and it may be different now in different places depending on their construct. But we need a lot of research to try to sort that out. The role and impact on team function. So it's easy to think about the individual nurse, the individual credential, the individual outcomes afforded by that person on the patient's care. As we all know, care is really more of a team sport than an individual sport. Trying to understand and tease out the individual impact of a particular individual nurse on care is difficult, but it may well be that credentialing provides an opportunity for that person to function and make the team better along any number of different constructs that will include but not be exclusive to patient outcomes that could be highly valued. So we need to think about that team construct. The last bullet that we came up with was how does credentialing shape future practice and improve care across various causal pathways? There's a number of reasons to believe that credentialing creates a culture and a milieu and a potential opportunity to shape how practice should be played out. And we do that all the time in different kinds of credentialing organizations. So this is the opportunity for organizations to shape what the future practice ought to be, and research could be undertaken to do that. Those are my comments, and let me see if anyone else who was there in our group would like to add anything that Jack and I may have overlooked.
All right, can we open the floor for questions? Yes, Patty.
Hi, I'm Patty Franklin. I'm Director of Professional Education at the University of Maryland. I have one question. If you go back to the slide of your framework, it's a comment and suggestion that cuts across many of the discussions. And first of all, thank you very much. This has been an excellent program. I appreciate the transparency and the engagement of the panel. It's been wonderful. If we look at the block that says patient care, I would suggest that we look at the model of care, because care is changing from the traditional acute care setting, even ambulatory care setting. It's out into the community, and we're regarding persons and person-centered care, persons who also need to maintain their health. They're not necessarily an individual with a medical problem. So we might look at expanding that concept from a patient care variable to a model of care and a person-centered care.
Let me just say that that's a really good point. And I think the parsimony of that doesn't carry the full richness as it should be. And we think about the world. One of the other comments that did come up was the notion that nurses are not always just delivering care to patients, as you point out, but sometimes to groups and populations. And so that should also encompass population care and population management.
Sheila Haas, Loyola University. I too want to speak to the patient care box. I think when you link, you had on the second slide for the second question, you link credentialing to outcomes. You need the intervening variable of what are they doing, so that in fact you can figure out, what works and perhaps what doesn't work. So there has to be a hefty piece of data collection on what is the practice. So it isn't just the model, but it's also what are they doing within that model.
Okay, so I absolutely agree with you, Sheila. But right now we saw some of that in the nurse performance box and some of it in this patient care box. Are there additions to the further additions to the framework that you would encourage us to make?
Well, given what came up in the discussion group too, hopefully it would be evidence-based, given the healthcare reform initiatives relative to evidence-based, but you'd want to know, is it evidence-based? Isn't it evidence-based? So I understand these are shrunken, but I was more responding also to the statement, the linkage of credentialing to outcomes. You've got to have that middle box of what are they doing that is uniquely contributing.
Thank you.
Linda?
Well, I think this is a rich discussion. I have a couple of comments, and we appreciate your feedback. I think it's important in the diagram in terms of the who, so that nurse to be able to collect data from those who are currently certified, those who were certified but are not now certified, those who were never certified, in terms of examining outcomes, because we find that some nurses get certified and they don't keep it up, in terms of that process? And is that an important piece for us to take a look at? And then I also would agree with Sheila, it's very important to look at the services that nurses are providing, the processes of care, and where they're providing those processes of care, not just in acute care, but what's happening every time nurses engage consumers, whether they be in homes, in schools, in community and society. And is there an impact in terms of dosing as it relates to the amount of exposure to, quote, this certified nurse and the services that he or she are providing to outcomes? I like the right-hand side of this because you get at the population health outcomes, which is extremely important, and not just individual patient care outcomes.
Linda, thank you. I have two reactions to what you've raised. One is what this doesn't capture in terms of the delivery of care that I think is central is this concept of handoffs, that patients are treated in multiple settings by multiple providers, often in each of those settings. I don't quite see how to change the chart to do that, but certainly the text, if I were rewriting it, would incorporate that as an additional dimension. And one of the challenges of doing research on this are the multiple number of hands that touch the patient and minds that touch the patient. So yes, I think that needs to be incorporated. The second issue you raise about the nature of the credentials, one of the individuals in the group was quite appropriately and very good at raising the issue of recredentialing. That was implicit in that discussion of sort of the life cycle, adding the time horizon to the nurse and what's going on there. And I think we need to add this concept of credentialed, formally credentialed, credentialable, credential eligible, to draw a complete parallel to the model of, if we're trying to understand the richness and variation within the workforce, what differences those potentially make.
Patrick Romano.
I'm Patrick Romano, UC Davis. Just a comment on the framework here. So I think conceptual frameworks are usually most helpful when they're relatively simple, but also highly flexible and adaptable. So as we reflect on the input from your group and bring this into this diagram, I guess I would encourage us to try to avoid making the diagram more complex, but to provide some asterisks, some description, a paragraph behind those boxes, of more like, well, this is what this really means. When we talk about nurse outcomes, we really mean team outcomes. When we talk about nurse performance, these are some examples of what we mean by performance. So just to provide a little bit of put a little flesh on the bone, so to speak.
Other questions? I'll follow up on Patrick's question. Can you talk a little bit about over-specificity of conceptual framework and really trying to get to every detail as opposed to identifying the concepts that are most important? So many of the things that we could add could go on endlessly. So how do you see this conceptual framework evolving, and how specific should it be? We can't get to the level of practice theory where A versus to B to C. Where are we going to land? Will this be sort of mid-range that we can apply? How specific does this need to be?
Okay, I think this does fall into mid-range. In January, I'm going to be teaching research design again, and the randomized control trial is the least theoretical and least conceptual model of research that we have, right? There's nothing but statistical theory there. You pick your outcome, you divide people up, and you run them down, and you do a t-test. And that works fine if you've got, frankly, if you don't understand very much about what's going on and you just want to know if there's a difference. But in the kind of work we're trying to do here, context matters a lot. And when I'm teaching this stuff, when I'm reflecting on my own research, I want my contextual model, my conceptual model, to be as rich as it can, because I want to think of all the other things that could explain my outcomes. And Joanne talked about the skepticism. Well, yeah, we've proven that there's an association between credentialing and this outcome, but I got 6 other explanations for that. Before I pay for credentialing, how do you convince me that credentialing is what's doing it? So I want the richness of everything else that could explain my outcome, because I need to think about how real those competing explanations are, whether I can incorporate them into my design. My design's going to look a lot simpler than this because I can't do everything in my conceptual model with the data I typically have. So I'm in this constant conversation between my conceptual model and my empirical analysis. And I think that to me is the way I think about this. I want the complexity in the conceptual model, and I want to know what I'm not going to be able to capture in my empirical analysis.
A couple of things I would add. As I mentioned in my group today, I'm an industrial engineer before I went into medicine and did a lot of modeling, and was always told that all models are wrong, some are useful. And what I generally observed is a lot of people who are novice to modeling but excited about it would just want to build a model and without the purpose in mind. And all experienced modelers would say, don't start building the model until you know the purpose for which it's being built. Otherwise, you'll never know the level of detail into which to go, because it can be an endless model. I can tell you the military has simulated World War III down to the individual soldier. It's a pretty detailed, sophisticated model. Manufacturing plants model the entire plant down to every line, every operation, very detailed, but they have specific reason why they're doing that. So this particular model was expanded over the original model that was parsimonious and displayed yesterday, and for a purpose, and that purpose was to help generate hypotheses and theories that should be tested, causal pathways about the research enterprise. Now, one could imagine in today's technology, you could hover over any of these boxes and see it expand, and that would also help generate ideas. And I asked my fellows to create these sort of models of their own research in great detail and be able to map up what everybody else has done in the literature and where the gaps are. So different levels of models are valuable for different purposes, and no one model is right for all those purposes. So this purpose, I think, was in large part driven by, can we help understand what kinds of research questions need to be addressed, and could help clarify to a variety of different readers what that might be, both at the arrows and at the boxes. And it's something that you could at least get your mind around a little bit. But trying to go into more detail will be of great value to the person who's diving into individual ones. Whether we captured that for that purpose well is certainly open to debate, but I think that was what its level is. And whenever you build these models, I think it's very important to sort of say, that's what I want to build it for, and then try to achieve that. It won't serve all purposes.
Any other questions? No, I feel like I could leave today and create a study using this model. I think it's pretty comprehensive and well done. Did Group 1 miss anything? Anything that should be there that's not? Any other recommendations? All right, congratulations to Group 1. Next, Ken, we'll turn to you.